We do find that the valves can have different disorders. When there's a valvular insufficiency, what this means is that there is now incompetence for that valve. And this is basically anything that's going to allow the blood to flow backward, something we do not want to have happen. So there can be something such as valvular stenosis. Basically, the cusps of the valve harden or get stiff, and therefore their function gets decreased or stops altogether. This can come from something such as rheumatic fever, which there used to be a lot of issues with rheumatic fever. Not so much, anymore in the U.S., but it does occur in other countries. We could have the heart get overworked, and the heart could become enlarged. And we usually hear these insufficiencies on auscultation. When people listen to the heart, when doctors listen to the heart, they can hear, and they might hear the regurgitation that's taking place, the blood flowing backward, and this would be termed a heart murmur. Another one that's pretty huge is mitral valve prolapse. This is where the mitral valves, one or both of them, they basically bulge up into the atria, and it's usually hereditary. About 1 in 40 people suffer from this, and it could cause some chest pain, shortness of breath. If it gets to be too severe, they can actually go in and do surgery. I'm not sure how successful that type of surgery might be, but I do know that this is a rather common problem with the valves. When we talk about those valves and the flow of the blood, we listen to this. This is called auscultation, where we listen to the sounds. When you're listening to the heart, for the most part, you're going to listen and you're going to hear two sounds. You're going to hear lub-dub, lub-dub, lub-dub. Each one of those sounds is indicative of something that's taking place. The first heart sound is when there's closure of those AV valves. Now, what we get is we get some turbulence, and the turbulence is actually what's creating the sound. The second sound, this is when the semilunars close. And each one, if you're listening to the heart, it should have a nice lub-dub, 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 lub-dub. Now, there is a third heart sound that's heard, but usually it's usually very prevalent in babies and children, Usually we lose that third sound as we get older. So, in people over 30, the third heart sound, it's very rarely heard. As you go through clinicals and so forth, you will be taught how to identify these sounds. When we talk about this beating of the heart, the sinus rhythm, this moving of the blood flow, this is going to be termed a cardiac cycle. And a cardiac cycle is one complete cycle of a contraction and a relaxation of all four chambers. And there are certain phases that occur in the cycle. We have ventricular filling, isovolumetric contraction, ventricular ejection, isovolumetric relaxation, and all of these phases they're completed in less than 1 second. If you remember, it's about 0.8 seconds for each one of those heartbeats to occur. So during contraction and relaxation is where we're going to see these cycles or these phases take place in the cardiac cycle. When we say the ventricular filling, well, this is dealing with the ventricles where they expand, the pressure drops, valves will open, blood gets to flow in. So when we talk about the filling of that ventricle, what'll take place is the first part is going to be that filling of the blood from the atria to the ventricle. That occurs very quickly. So they call that rapid filling or the rapid ventricular filling. Now, the diastasis, this one is where there's a slower filling of the heart. This is part of the P wave. And then at the final point, the final filling of the ventricle, basically what will happen is the blood that has been moving from the atria to the ventricles, the atria will actually do a contraction because, they're going to contract. And then that contraction pushes out that blood so that last little bit of it moves into the ventricles. Now, there is some math that's involved with this. I'm not going to I don't want you to know this math, just want you to be familiar with it. So these volumes, because, blood is a fluid, there are volumes and there are normal volumes that should be present. And so since this ventricular filling is taking place and it's being done in diastole, it says that when that atria does that final contraction, there's an end volume and it should be about 130 milliliters of blood. That's roughly the norm for that number. But like I said, there's going to be a slide with that on there, but I'm not expecting you to try to keep up with that, okay? For the isovolumetric contraction. Iso means the same. So what we're going to see is the atria will do their contraction and then they will begin their relaxation, and that's where they'll stay until the cycle is over. The ventricles that have filled with blood, those ventricles need to depolarize. This is the QRS complex. Once those ventricles depolarize, they're going to start their contraction. So during the isovolumetric, the AV valves will close. The heart sound 1 is at the beginning of this phase. And even though we have begun the contraction, blood is not going to leave the heart, the ventricles just yet, okay? Because we've only begun the depolarization. We have to finish the depolarization. So once we reach ejection, this is where the pressures have gotten high, and at that point, note the pressure that's in there. 120 over 20, this 120 and 25. Well, guess what that 120 correlates to? Yep, you got it. Numbers that we take with blood pressure. So when that ventricle begins to contract, that contraction, basically the blood comes out very quickly, and that creates that huge amount of pressure. And that pressure, what it'll do is it will begin to move into the arteries. And the way that we're going to measure blood pressure, we're going to be measuring it based upon the cuff that gets used. And so if you know, what we know is that the norm should roughly be for the pressure in that artery to be about 120 millimeters. And so this correlates to the blood leaving the ventricles of the heart. And so once again, they've got some math here, but like I said, we're going to come to a slide with that on there. Now, the relaxation. With the relaxation, this is where the ventricles are going to start to expand. Pressure is going to start to go down in the ventricles. And at this point, we're going to begin to see, we're going to begin to hear the second heart sound. So what we begin to see is that the AV valves, the semilunars have closed, the AV are closed, and at this point, we're going to find that the atria are filling up again with blood, and the process is going to start all over again. So, this cardiac cycle that takes place, this is about how long it lasts. And note, it totals about 0.8 seconds, therefore giving us roughly the 75 heartbeats per minute. And we do get to return to the resting membrane potential before the process starts all over again. This is how it begins to look if we put it into a graph form, and the way that we correlate it to the EKG, the heart sounds that take place, the phases that are occurring, whether we're looking at the filling or whether we're looking at the contraction, and how we begin to correlate sounds to the waves, to the function of an area of the heart. Are we looking at the function of a ventricle and atria and so forth? So, this cardiac cycle, like I said, we look at having a particular amount of blood. And so, when we begin to see the amount of volume, this blood that's present, okay, we usually have some blood left over in the heart. Now, it's not blood that's going to stay stagnant, okay? It's just a leftover amount in the heart, and it'll continuously get, used and stay, something will continue to stay behind. So, as we begin to have the atria fill, okay, by the time the atria have filled, we have an amount, and this should be the norm, okay? Then, if we have 60 that were left over, we fill up with about 70. That still gives us about 130 milliliter volume in the ventricles of the heart. And then if we have the ventricles begin to contract, push out the blood, about 70 milliliters should get pushed out, leaving the 60 milliliters behind, so that we can keep the volume of the heart constant. This becomes important because, for the most part, both sides of the heart are going to eject the same volume at the same time, even though their pressures are different, because the pressure on the right side of the heart does not need to be that 120 like we see on the left side of the heart, because the left side has to go to the whole body, the right only has to go to the lungs. When a person is in congestive heart failure, usually one of those ventricles are not ejecting blood correctly. And it's usually due to something that has gone wrong. Usually, it could be associated with a heart attack, someone who has chronic hypertension, which is high blood pressure. It could be their valves have something wrong, or it could actually be a congenital defect in the heart. So the volume of the heart is a very good clinical indicator of something that can go wrong or be wrong with the heart.